My name is Raman Uberoi. I'm an interventional consultant at the John Radcliffe Hospital in Oxford in the UK, and I'm speaking at the CIRSE Congress in 2018 in the sunny town of Lisbon. So planning and patient selection is vital. In my opinion, it's almost 80% of the procedure. If you do good patient selection and planning, it makes the rest of the procedure itself, the technical aspects of it, much more straightforward. And in terms of patient selection, there are several things you need to consider. Firstly, what is the age of the patient? What is the anatomical features of the patient? And that includes the neck and other features such as access, such as what size of the iliac vessels they have, tortuosity, the length of the lesion, and any suprarenal issues that might create problems for deployment and fixation of the device. You then have to pick the right device. There are many choices available in the market, but we know some perform differently depending on different issues, for example, such as the neck, so angulation and tortuosity being one of those strong features. That may predict poorer outcomes, but some devices mold better to that than others. We know that if you get good patient selection, we will get a better immediate and long-term outcome, and we will have to deal with fewer issues. If we start moving into more challenging territories, the rates and numbers of interventions increase, and the complexity, not just the immediate procedure, but also subsequent interventions becomes more problematic, and therefore selection is really vital to ensuring the best outcome for the patient. And we need to put the patient at the center of our treatments. Sometimes we do things because we can, rather than thinking this is what is going to give the best outcome for the patient. And that might include thinking of alternative procedures, including surgery. And although as an endovascular enthusiast, I always would like to put endovascular first, you still, as a clinician, need to think about what are the possible other options. And surgery certainly is a good option for the right patients. Again, having the discussion at the MDT and selecting the appropriate patients is a key part of their strategy. If they're young patients, if they've got favorable ASA grades, and we know that they're going to have potentially a long life going beyond 60, 70, 80, even 90, then maybe a surgical option is better for that patient. Similarly, there may be patients who are unsuitable for both, and rather trying to shoehorn a device or a particular system because we can is maybe not the best thing for the patient, and is also perhaps not the best thing for the clinicians and the specialty or the hospital. A good neck for EVAR is one that has at least 15 millimeters, and in the past this was mandatory for planning stent grafts. It should have parallel sides, there should be no tapering reverse or conical shapes. It should have even edges, no saccular conformation, and of course thrombus and calcification have also been considered to be poor markers for a long-term outcome. Angulations are also strong predictors of poor outcomes in developing complications such as type 1A leaks, and therefore having a good neck is a key part of planning an EVAR and making sure we get good immediate and long-term outcomes. Now, with increasing technological evolutions, we are now talking about maybe having shorter necks with 10 millimeters, or having necks that potentially in the past we would have considered were too challenging to place stent grafts, but there is some data that of course some of these can be tackled with some of these newer devices. But of course the data to date suggests that ideally we should have as much of a good quality neck as possible. And there's also some data that things that we considered were perhaps not so good, such as mural thrombus, may not be such an issue, and there are some papers actually suggesting that having a bit of thrombus is actually protective against type 1A endo leaks. But if you want to get a good outcome, you have to select the patients, you have to select what is the optimal anatomy for that patient, and then of course try and match that to the devices. And not all devices behave exactly the same, so it's trying to get the best device for the particular specifics of that patient's anatomical features.